Hello, and welcome to The Issue on the ASGCT Podcast Network. I'm your host, Emily Walsh-Martin, and today I'm joined by Melissa Majerol, the model lead for the Cell and Gene Therapy Access Model at the Center for Medicare and Medicaid Innovation, also known as CMMI, at CMS. Melissa is an amazing health policy expert, and she's going to take us step by step through some pretty complex health policy that impacts what happens between BLA and a patient finally accessing an FDA-approved therapy via Medicaid. Importantly, she's going to share the goals of the CMMI Access Model program, which seeks to find innovative ways to simplify access to novel therapies while bridging economic risk sharing between state Medicaid agencies and manufacturers to ensure patient access to these novel therapies. But first, ASGCT's Empowering Patients Summit is back for its second year, and it's completely free and virtual. Taking place on March 11th and 12th from 10 a.m. to 1 p.m. Eastern, this two-day event brings together leading experts in cell and gene therapy who are shaping the science and centering the patient voice. Attendees will learn the latest on CGT approaches, research strategies, regulatory trends, and key updates for the patient community. If you're a patient, caregiver, advocate, or someone navigating this evolving space, this summit is for you. Learn more and register today at asgct.org/empowering. And now, on to the show. Welcome to The Issue on the ASGCT Podcast Network. Melissa Majerol from the Centers for Medicare and Medicaid Services in the Center for Medicare and Medicaid Innovation, where she serves as model lead for cell and gene therapy access models. Thank you so much for coming on the podcast.
Thank you so much for having me. It's a pleasure to be here.
Now, before the role that you're currently in, you had a series of, dare I say, very interesting health policy roles at the Harvard T.H. Chan School of Public Health, Kaiser Family Foundation, and Deloitte. Can you share a little bit about what health policy encompasses? Because I think that may be a little bit of a black box for our audience, but also share about your career path and sort of how you came to your current role.
Sure. So I think my perspective on health policy is really focused on healthcare, for me at least. So really how it's financed, how it's delivered, and how patients ultimately experience the healthcare system. Of course, patients aren't a monolith. So people often experience the healthcare system in vastly different ways, depending on their income, age, gender, location, the kind of health insurance they have, or whether they have health insurance at all. And so for me, health policy really encompasses all of that. So you asked a little bit about my career trajectory. I got my master's in health policy at the Harvard School of Public Health in 2014. This is right around the time that the Affordable Care Act is first being implemented. And there were a lot of conversations about health exchanges, Medicaid expansion, the uninsured population, and of course, the really high cost of healthcare in the United States. You know, problems we've solved completely 12 years later. And these were all issues that were and continue to be very near and dear to my heart. And honestly, the reason I wanted to pursue a career in health policy in the first place. I worked as a teacher's assistant for a massive open online course while I was a grad student. This was an introduction to U.S. health policy and had students enrolled from literally all over the world. I learned so much teaching that course. And I think I learned what health policy meant really through that course. After graduation, I got my first big break as a health policy analyst on the Medicaid and uninsured team at the Kaiser Family Foundation. And that was a really great job. And I learned there again so much about Medicaid policy, the Affordable Care Act, and the remaining uninsured. After a few years there, I worked at Deloitte Center for Government Insights. This is a part of Deloitte that is not part of the consulting arm, but really a research and support arm. And there I researched and wrote about federal and state health policy. Started out by focusing on some of the early discussions related to health reform back in 2016, and then writing a lot about social drivers of health, rural health, and telehealth.
Hmm.
And I then joined the Innovation Center at CMS 6 years ago, where I still am today. And I had the opportunity there to work on all kinds of really interesting projects. I did a detail at the Center for Medicaid and CHIP Services just as COVID hit to help that
Hmm.
state demonstrations team there process and deal with pandemic requests coming from states. I also worked as special assistant to the chief strategy officer at the Innovation Center. And then about 3 years ago, I started working as a model lead on the Cell and Gene Therapy Access Model, which I have to say has definitely been the most gratifying and really interesting role I've ever had. I think we're probably going to get into the nitty-gritty of the model in a little bit, but at a really high level, this is a Medicaid-focused model whose goal it is to increase access to expensive cell and gene therapies for Medicaid beneficiaries. And the goal is to do so by making it easier for states to pay for these drugs. So I think the through line, I have to say, across these different jobs that I've had is really Medicaid has been at the focus primarily the entire time.
Got it. Got it. And there's so much I think we'll need to demystify for our audience about that. We have had one guest on the podcast in the past who was, as I guess, understand it, basically helping patients navigate that sort of that last mile to actually receiving a therapy after a diagnosis. And that was a super enlightening discussion. I think this one is going to be even more enlightening because most of us, I think, who belong to ASGCT, access our healthcare through private payer. And so there's a bit of a mystery and an unknown about how, Medicaid works. And for those of us who haven't yet reached the age, also probably a little bit of a mystery about Medicare. And so if you don't mind, we'll take this step by step and first just ask some very simple 101 type questions. So, I guess first up, what is Medicare? What is Medicaid? Who does each serve? And what percentages of the US population are we talking about here?
Medicare is a federal program that primarily serves people age 65 and over, and that is regardless of income. And there are about 68 million people, or 20% of the US population, currently covered by Medicare. Medicaid, on the other hand, is a program for people with low income. And it covers about 70 million people in the United States, again, just a little over 20% of the US population. So whereas Medicare is paid for and administered by the federal government alone, Medicaid is often referred to as a state-federal partnership because it's jointly financed by states and the federal government, and it's administered by states, but really states need to operate under broad federal rules. So because states have the flexibility to determine to some degree what populations and services to cover, how to deliver care, and how much to reimburse providers, there is significant variation across states in program spending and also the share of people covered by the program. And then finally, not to confuse people too much, but I'll just briefly mention that some people are covered by both Medicare and Medicaid at the same time. These people are often referred to as dual eligibles. And these are generally people who are either over 65 with very low incomes or under 65 with a qualifying disability.
Got it. And the qualifying disability, correct me if I'm wrong, but we're about to dive in deep into the sickle cell model that you helped to establish. But is sickle cell one of those qualifying disabilities where people might be dual?
No, not specifically. There's
Okay.
end-stage renal disease, there's Lou Gehrig's disease, and then there are individuals who have been on Social Security disability insurance for over 24 months, I believe, become
Okay.
qualified for Medicare. But sickle
Got
cell is
it.
not. a specific condition that
Got
would
it.
allow
So
you to.
sickle cell is not called out as one of those conditions, but if someone did go on Social Security disability for greater than 24 months with sickle cell, they might be dual eligible.
Yeah, yeah, that's
Okay.
right. And I will say that most individuals with sickle cell disease who are eligible for Medicaid are eligible through the disability pathway for Medicaid. So there are various ways to become eligible for Medicaid, and one of those is through a disability pathway.
Got it. Okay. And, I realize I have a little bit of a follow-up. In part, this goes back to how much I love the policy summit from ASGCT because every time I go, I learn something new. But one of the things that, and this is, I think, where the CMMI really plays an amazing sort of role in moving us maybe forward for access for these kinds of therapies. But if you're developing a drug and that drug happens to be something that treats a condition that is common among people who are receiving access through Medicaid, the way it used to work, right, is that the sponsor company would have to, the manufacturer would have to go sort of state by state and have independent conversations one by one by one. But like that's what CMMI is really trying to sort of help streamline and get their arms around, right?
Yeah, so I will say once a drug becomes FDA approved, state Medicaid agencies are basically required to cover those drugs. However, they do have broad latitude in, sort of putting utilization management or prior authorization criteria, which could limit who's able to access the drug in a way that's more narrow, for example, than the FDA label. So I wouldn't say that manufacturers are required to go state by
Mm,
state. However, if they want to strike deals with states for supplemental rebates in order to be put on their preferred drug list, for example, or to negotiate an access policy that is broader than the one the state might decide to implement on their own, then yes, they would have to do that one by one, state by state. There are also drug pools that represent several states at a time. It's another
mm.
thing, but generally speaking, yeah, it's sort of a state by state thing.
Right. And, I think that was for me kind of an eye opener just because I don't know what kind of magical thinking I had when I started my career, but I basically just said, okay, we just got to get it over the line, get the BLA, and then people will be able to get it. But there's a lot that happens after that. So maybe let's dive in. Let's talk about the CMMI, how it was created, how long has it been around, and sort of what is its mandate to try to help, I guess, grease the access to patients in need.
Yeah, so the Center for Medicare and Medicaid Innovation was established by Congress in 2010 under the Affordable Care Act. It's been operational since 2011, and it was created really as a laboratory to test new ideas related to how we pay for and or deliver healthcare, with the goal of improving quality and healthcare outcomes and reducing federal spending. The idea is really to move away from a system that rewards quantity to one that pays for quality, or what's often referred to as value over volume. And CMMI statute requires CMMI to evaluate each and every one of these ideas, or what we refer to as models, for the impact that they have on the quality of care and federal spending. And if the evaluation finds that these models have been successful in terms of improving quality of care or reducing federal spending, these models can be expanded either in scope or duration by the Secretary of Health and Human Services. And so I think it's a really ambitious agency that is taking on an extremely difficult and complex problem in the healthcare system.
Right. And I like how you put it. It's sort of that dual goal of, improving care, but also reducing spend, federal spending, and trying to find, indications and therapies that help you achieve those dual goals sort of at the same time. So, Melissa, when CMMI decided to take on the development of a cell and gene therapy model, what was the goal of doing that, and what was the problem you were hoping to solve?
So we had been watching these very expensive cell and gene therapies coming to market at an increasingly rapid pace. It's not uncommon to see list prices upwards of $2 million per person. And while many of these therapies are transformative and hold the potential to cure severe diseases that previously had few, if any, good treatment alternatives, we still do not have a lot of real world data about how they work in the real world, how durable they are, and how long patients can expect to see the results that we've seen in clinical trials. And so the result is that payers, including Medicaid agencies, are somewhat hesitant to provide broad access to these therapies. And then manufacturers, in turn, struggle to obtain the market access that's necessary to justify future investments in similar therapies. And so the cell and gene therapy access model attempts to resolve what you might call a market inefficiency by pooling state negotiating power to secure upfront discounts and then financial assurances and accountability from manufacturers. And so the way this works is under this voluntary model, CMS negotiates directly with CGT drug manufacturers on behalf of state Medicaid agencies for a single pricing structure with each manufacturer that includes upfront discounts on each unit of the drug and requires additional rebates if Medicaid beneficiaries in participating states don't experience the promised benefits of the therapy. And in return, states are required to adopt and implement a standardized access policy that's negotiated between manufacturers and CMS.
Maybe now is a good time to just sort of seg straight into, sickle cell disease, and the recent, FDA approvals of Casgevy and Lyfgenia. And just, for people who listen to this podcast frequently, they know that I worked on Casgevy once upon a time, from the time it was in discovery till just entering the clinic for the first time. So many, many moons ago. But I think, can you talk about how CMMI got engaged with sickle cell and specifically those two products, and sort of what the path was there?
Yeah, absolutely. So we were asked to come up with a few different model ideas that would address the high cost of prescription drugs for Medicare and Medicaid beneficiaries. And so we reached out to really smart people, researchers, academics, clinicians, all sorts of important interested parties. And what we heard a lot again and again is cell and gene therapies. They're going to kill us. They're going to crush us. Like, the costs are just so high. We don't know what to do. And so Casgevy and Lyfgenia were approved in December of 2023 by the FDA, but we started designing this model with a focus on sickle cell disease and really these drugs about a year before that. We waited until the drugs were approved by the FDA before announcing the model and specifically its focus on sickle cell disease as its first condition of interest. But we didn't begin negotiations with manufacturers until a few months after that, even though we had our eyes on these drugs for a really long time.
That makes sense. And so, I guess hindsight, like, do you feel like a year gave you the right lead time such that you were sort of ready to have those conversations with the manufacturers once approval came through?
Yeah, I mean, during that time, we did a lot of prep work. We talked to everybody that we thought we needed to talk to. We talked to patient groups about what, the patient journey is for this treatment and how really complex and difficult it is. We developed an optional funding opportunity for states to help them address some of the access barriers, particularly for Medicaid beneficiaries who don't have as many resources as privately insured individuals. We, really focused on what were the outcomes. I haven't really talked about the model itself yet, but, this is a model in which if patients do not, experience the therapeutic benefits of the model, manufacturers are required to give some portion of the money of the drug back to the states.
Yep.
And so we focused on what are these outcomes? What are the data sources for these outcomes? How long will we track patients for? yeah, so we took that time to really plan a very disease specific launch of this model. Although I will
Yeah.
say, this is the cell and gene therapy access model, not the sickle cell model. And so we don't plan on stopping with sickle cell, but that was where we started.
Got it. Yeah. And one of the things you said at the ASGC Policy Summit a few months ago was that sickle cell was kind of a perfect sort of starting case. And can you talk a little bit about the disease, the patient journey on that disease, and sort of what made it so well suited to start to innovate around?
There are a few things, but I think the first thing that's important to mention is that this is a voluntary model. Manufacturers and states are the two participants that are, coming into the model, and they come to the table voluntarily. So
Yep.
we needed a disease condition that we knew states cared about and were worried about in terms of the impact on their budget.
Yeah.
And these two drugs we knew were going to be very expensive, even though we didn't have the list price at the time. We knew that they were going to be very expensive. And sickle cell disease is the most common rare disease in the United States. It doesn't impact every state equally. There are some states, particularly those in the South, that have a much higher sickle cell population than in other parts of the country. And so certain states in particular knew that they were going to get hit really hard, that there were going to be a lot
Right.
of Medicaid beneficiaries that would be eligible and interested. And so, we were just being responsive to what we heard from states, which was these drugs are the ones that we want help with. And then the other thing is that they're brand new drugs. And so we didn't have a lot of long-term, real world data about how well they actually worked, even though
Right.
they are sort of advertised as cures or at least very transformative therapies. And so we knew that states were going to want financial assurances if the drugs did not work as promised. So I think we can talk a little bit more about the structure of the model in a bit,
Yeah.
but this is sort of what we tried to solve for.
Right. And so let's dive into that the structure of the model, like so, and just so everyone's aware, there are 35 states and territories, right, who've sort of volunteered to buy into this model. But how is the model structured?
Yeah. So basically, the idea is that CMS put out a request for applications specifically for drugs that were FDA approved, gene therapies that were FDA approved to treat or cure sickle cell disease. And we then went through a sort of 6 or 7 month negotiation period in which we negotiated on what the price terms would be, what the outcomes would be, what the measurement period for those outcomes would be. But also, really, the idea was that we were going to bring as many states as possible to the table. And frankly, we ended up with more states than we could have ever hoped for. But what we told the manufacturers were we are representing all the states. We are negotiating on behalf of all the states, and the better the deal is, the more states will join. And so, we wanted upfront discounts for these drugs, but we also wanted rebates in case these drugs did not work as promised, rebates back to states. And so that's what we were able to negotiate. We shared the details of those contracts with the states as soon as we executed them with the manufacturers. We gave states a few months to think about it, mull it over, and then apply for the model. And yeah, we're currently, calendar year 2025 is a kind of a rolling start year for the model. So states were able to join anytime between January 1, 2025 and January 1, 2026.
Okay.
There have been things that's to do in order to get ready for the model. And so we wanted to give states time to do that. But yeah, so everything kind of goes fully live in 2026, which is really exciting. It's been a long time
Yeah.
coming.
So just to recap, so basically you're having conversations with the two manufacturers, coming up with the sort of structure of what the upfront payment they'll receive is, what the rebate is, which is basically at a certain point in time, if the patient hasn't received the benefit that's agreed to in the model, then, some money comes back, right? Is that how that works?
Yeah, that's exactly it. And CMS has taken on the role not only of negotiating these deals, but also of collecting this outcomes data, aggregating it, analyzing
Wow.
it, calculating the rebates, and sort of adjudicating any disputes between the states and the manufacturer. So, we've really taken on this role that we understood a lot of states were not able to take on their own.
Yeah, that's really interesting to me because I remember, once upon a time, those were all the questions. Like, okay, if you do want to do some sort of rebate where if, the benefit doesn't persist, let's say isn't durable, or never initiates, like there's money that comes back. Like, who's collecting that data? What happens if that patient changes states during that time? Like, how do you keep track of all of these patients? And make sure that things run smoothly on a rebate system. And so you've centralized that is what you're saying.
Yeah, exactly. I mean, as the Center for Medicare and Medicaid Services, we already receive data from states on a monthly, claims-based data from states on a monthly basis. So
Yeah.
we're already collecting that data. If a person moves from one state Medicaid program to another, we would, of course, continue to receive the data, but from a different state. If the beneficiary becomes eligible for Medicare, we would also receive that data through our Medicare claims data. And we're also working to procure a commercial data aggregator in the event that a person becomes eligible for commercial insurance. And we still
Got
need to
it.
track them.
That makes a ton of sense. And I think that was one of the things you mentioned at the policy summit, that one of the particular reasons why CMMI was interested in these therapies, this indication, is that you might be able to see a lot of patients sort of transition back into the workforce because if they really do receive the benefit that the drugs are hoping to provide, they might be able to transition back and transition to private payers, and that sort of helps with that dual goal, right, of both bringing value to patients in terms of potentially curative or very improved health statuses, and then at the same time sort of saving the amount of Medicaid and Medicare spend.
Yeah, I mean, I would say the ultimate goal is to cure these patients and allow them to live full and regular lives. As far as, our requirement at the Innovation Center to only launch models that can plausibly improve health outcomes and or reduce health spending, part of it too is that we are we are already living in a world in which these drugs exist. So we're not sort of comparing ourselves to a world in which they haven't existed. What we know is that we're negotiating discounts and rebates that we believe are competitive, with respect or compared to what states would be able to get on their own. And I
Mhm.
think that that is evident from the fact that 35 states decided to join the model.
Right. Exactly. Exactly. So one of the other aspects of the model that I'd love for us to double click on is both of these therapies have sort of a number of steps required in order to receive them. And one of those steps actually can impact, fertility of the patient being treated. And I know, I recall early days, there were a bunch of news headlines on whether or not fertility preservation is something that the manufacturers could help to sponsor for patients who receive these therapies. And I'd love if you could sort of peel back the onion on that a bit and walk us through what sort of HHS rules are around this, and then how the CMMI mandate sort of allowed for the outcome that I think we now have, which is that Medicaid patients can now access fertility preservation services if they receive Casgevy or Lyfgenia.
Yeah, so as you mentioned, and as we've talked about, this is an incredibly difficult and long patient journey. And right before the patient receives the infusion of their modified cells, they do have to have a very intense chemotherapy preconditioning. And unfortunately, this does typically lead to infertility. And because the drug is approved for people as young as 12, of course, many of these individuals have not even contemplated the question of children, but they, in many cases, do not want to foreclose that option. And so, both manufacturers that offer gene therapies for sickle cell disease, they already pay for fertility preservation services for patients that have commercial insurance.
Right.
But because of federal fraud and abuse laws that prohibit manufacturers from giving Medicaid patients something of value, in this case, fertility preservation services, which are quite expensive, the concern is that this would lead to some sort of patient inducement or violate the anti-kickback statute. But CMS and manufacturers both recognized that this was really important for this patient population and that eligible patients might actually forego treatment without the option to preserve their fertility. And so the Innovation Center used its unique authority to basically protect manufacturers who paid for fertility services from liability under the anti-kickback statute through a CMS-sponsored model safe harbor, and not only permitted, but required manufacturers to cover a defined scope of fertility preservation services for Medicaid beneficiaries living in states that are participating in the model and receiving one of these two drugs.
That makes a lot of sense, and I mean I think you summarized it very nicely. But right, with a disease like sickle cell, it's debilitating. It affects you from a young age, and being able to access one of these therapies at that young age can really have an impact on your future quality of life and your health status moving forward. And so I think it's remarkable and laudable that CMS was able to figure this out for the patients so that they don't have to make a trade on their future fertility versus receiving these therapies. So kudos to you guys for that. That's really important.
Yeah, we are really happy that we were able to include this as part of the model.
So we're at the end of our time, and I get to ask my favorite final question, which is I'm very interested in your answer because a lot of times, certainly, I sometimes have the very technical answers to this question, which is something about how drugs are developed. But I'm curious for you, if you could wave a wand and fix one thing for cell and gene therapy development, what would it be?
So I think that there is no doubt that cell and gene therapy is the future of medicine. And so I think that if we could just bring the costs down, we could bring these incredibly transformative therapies to patients more quickly and more easily. So because I have the benefit of magic wand, I don't think I need to think too hard about how this happens, but really just bringing them to market in a much cheaper and easier way, and then making it cheaper for payers or patients to access these therapies, I think would really solve everything.
Right. Absolutely. So yes, let's hope that your magic wand comes to pass. And but yeah, I think you're right. I think if we can figure out a way to reduce costs either by streamlining the path to development or through some, leaps forward in technological sort of levers that could help us develop more cheaply or manufacture more cheaply, that would be an absolutely fantastic thing. So, Melissa, thank you so much for joining us today and for sharing the work that you do. It's such important work. It is critical to the work that we do, at the bench and then in the clinic. That there's someone like you thinking hard about these things and trying to help us figure out those steps that happen after BLA and before a patient gets an approved drug. So thank you so much.
Thank you so much for having me.